Show you a case of a patient who presents himself or herself to the radiotherapy department with cancer, and what the several steps are to treat that patient. And there's also some simulation, so I hope that everything runs well. You might be sleeping. Good, to start off. So what's radiotherapy? Radiotherapy is another name for radiation oncology, and it's sort of it stands in the middle of the clinic, so where a patient with cancer presents himself, so a patient has disease. You have also biological part, so the biological response of radiotherapy, so how does a cell react on irradiation. And we will discuss some responses on tumor level, so that's what we want, and on normal tissue level, so that's what we do not want. And then at the third part, there's also some radiation physics behind it. So how does it look in clinical practice? So how many patients and what kind of cancers do receive radiotherapy as a treatment? So if we look, so over here you have the tumor type, so it goes from breast, lung to unknown or other tumors. This is the proportion of all cancers, so how many percent of the patients who have cancer get breast cancer or lung cancer. This is the proportion of the patients who get radiotherapy, and then the patients who get radiotherapy as a percentage of all cancers. So we notice that for breast cancer, which is the highest percentage of cancer incidence in the population, most of them get radiotherapy, so 83% of them gets radiotherapy. And lung, also a high number gets radiotherapy. So in essentially all the red boxes are cancer sites who get from which most patients receive radiotherapy. So if we then look in total, sort of speaking, almost or somewhat higher than 50%, so more than half of the cancer patients receive radiotherapy as a treatment. So it is an important treatment modality next to surgery and chemotherapy, or can be combined as well with the other two. So within radiation oncology, there's a concept of the 3 C's. And the C stands for cure, it's cheap, and it's conservative. So the first C, the cure C, I made sort of a hypothetical example. So assume you have 100 new cases, patients that have cancer. 30 of them are skin cancer or in situ cervical cancer. 48 are localized and operable, so it can be lung cancer, can be a breast cancer. 22 are an advanced cancer. So, as an example, can be lung cancer with metastasis to the brain, for example. So if we look more in detail to these localized and operable cancers, 30 of them can be cured by surgery alone or combined with radiotherapy. 18 of them cannot be cured, so they show a relapse, so cancer comes back after treatment. So if you combine these relapsed, these 18, with this 22 advanced, you have 40 patients who are eligible or candidate for chemotherapy. So if we look to the success rate for chemotherapy, we see that 5 of these 40 are potentially curable, while 35 are not curable. So from these 5 who are curable, 2 can be cured by chemotherapy alone. If we look to these 35 incurable, what happens with these patients? They get palliative treatment to do a life prolongation, which is, well, 10 of them can be successful out of these 35. So let's say 25 will die. So if then combine radiotherapy or chemotherapy, we see that radiotherapy can cure 30 cases, while chemotherapy alone can cure only 2 cases. So in that sense, first C stands for cure with radiotherapy. So what are the indications for radiotherapy? Well, you can treat cancer with radiotherapy in a curative setting. So that means that these tumors, the primary tumors, for example, lung tumor, breast tumor, rectum tumor, should not show any metastasis. Otherwise, it's most of the cases not curative anymore. And this can be combined with other treatments. Like for example, for head and neck cancer patients, radiotherapy is combined with chemotherapy. This treatment is called the RAD-PLAT. So RAD stands for radiotherapy, PLAT stands for cisplatin, that's a chemotherapeutic drug. Another way to treat radiotherapy is in an adjuvant setting. This can be done before another treatment, so it can be done before chemotherapy or surgery, and it's with the idea to reduce the tumor size. It can also be done after another treatment. So, and this is done, for example, after surgery, it can also be done after chemotherapy, is to remove the remaining tumor cells. And then a third indication to treat patients with radiotherapy is palliative radiotherapy. So this is not a curative treatment at all. So you don't cure patients when you do a palliative treatment. This is only done to reduce tumor burden and in most cases to relieve the pain from removal of an obstruction, for example. So if you have a pancreatic cancer which is invasive and metastasizing, it metastasizes to the liver, it also blocks the sphincter in the stomach, so if you take in food, your food cannot pass through anymore from the stomach into your intestines by this pancreatic invasive tumor. So in that case, so these patients are incurable, these will receive a high dose of radiotherapy in a palliative settings, just to reduce this pancreatic tumor, for example, to make sure that the obstruction from stomach into the gut or the bowels is removed. It's also a C for cheap. And why is it cheap? Well, the costs, like this is now a study from Sweden, but it counts for the whole Europe. It's cheap because radiotherapy is only 5% of the total cost of cancer treatment within, well, now Sweden or the European community. The other 95% are divided by surgery and chemotherapy, while chemotherapy stands for almost 70% of the cancer costs. So pharmaceutical companies earn a lot of money by having these chemotherapeutic drugs, although they are not always working properly. And the third C stands for it's a conservative treatment. Why is it conservative? Well, it's a localized treatment as compared with chemotherapy. Chemotherapy is usually injected intravenously, so it's a systemic treatment, so it goes everywhere, to the normal cells, to the tumor cells. While for radiotherapy or radiation, it's done in such a way that you try to hit the tumor as much as possible, sparing normal healthy tissue. You will see an example later on. So the general aim of radiotherapy is So it's based on the exposure of malignant tumor cells or malignant tumor in such a way to localize dose of radiation towards these cells in order to destroy the tumor cell. So the goal is to maximize the dose to the tumor location or to the tumor cells and to minimize the exposure or the dose to the normal surrounding body. So there are two types of radiotherapy. So the first one is external radiotherapy, or using an external beam, and this is also called teletherapy. And this uses charged particles exposed or made by linear accelerators. So these are photons and or called X-rays. The exposure time for a patient during a radiotherapy treatment on one day is around 15 minutes. These 15 minutes that encompasses 2 minutes of radiation and let's say 10 minutes to position the patient on the bed. It can be used for lung, breast, colon, kidney cancer, head and neck cancer. And well, this is an example or a picture of our good friend Röntgen, who sort of discovered these X-rays. So if we look here to the bottom right, we see that the number of patients treated with external beam radiotherapy or teletherapy is increasing over time. So how does this external beam radiation goes? Well, if we look back 50 years ago, or more than 50 years ago, this is the patient who sits on a regular chair, for example. You have here the beam, the linac, who produces the X-rays, and behind the patient you have a fluoroscope. So an attempt to visualize also these beams. And while this is a static linac, so it's just hanging on the wall or on the ceiling, and the patient is placed on a rotating chair. So they tried to do already some conformal radiotherapy, so based on the shape of the tumor, by doing this by rotating the chair with the patient on top of it. So yeah, well, you can see that this treatment is quite crude, but well, it's from more than 50 years ago. This is where we are now. We are now at VMAT radiotherapy, and it stands for volumetric modulated arc therapy. So this is what we're using currently in master clinic. So we have the newest Linacs, and these are variant through beams. Over here on the head, this produces the X-rays. This is connected to this X-ray tube, so it travels the whole way towards the head. Patient is positioned over here, so the irradiation comes from top to down, so to speak. There are some imaging panels, so like you see over here and here. This is also to see what kind of or how much radiation or X-rays goes through the patient. Then you can get these sort of projections. So we call this CT projection per beam angle. So there you see how more red, which is coming up, or more dose is delivered inside the patient. And this is measured by using these imaging panels outside of the patient. You can also then see what's the transit dose per beam. So this is sort of these lines that move up and down. And again, the red is the highest dose deposition, blue is lowest dose deposition. So now we can see even during the treatment itself where the dose is deposited. So you see that in this case the dose is deposited here in the upper left lung. So this is sort of an animation which is not working. Yeah, sorry for that. So in essentially it's the same Linac. Now the collimator is over here, so the Linac is also able to rotate around the patient. So the beams are coming from here and go through the patient. So this is a patient with a lung tumor. Well, you don't see a tumor, but you see the beams going through the lung area. And then what the beams travel further and further on and ends up in an imaging panel. So we do imaging during radiotherapy to see where dose is delivered. The second type of radiotherapy is internal beam radiation or brachytherapy. So this uses internal radiation sources or seeds which are radioactive. Now they are placed in such a way that they are very close or even inside the tumor. And for these we use gamma rays. Exposure can be hours to days because it depends on the decay speed of the radioactive isotope itself. And it's mainly used for prostate, bladder, cervix cancer, but can also be used for head and neck. And you also see that over the last years that the number of patients treated with brachytherapy is also increasing. So over here in this table, this is sort of a list with all radioisotopes that can be used for brachytherapy. And nowadays in clinic, it's mainly iridium and iodine, who has sort of a similar half-life, so 60 days. So those two are used for mainly used for brachytherapy. We don't want to use, well, it's possible to use, for example, cesium. This has a half-life of 30 years. But if you implant cesium seeds in a prostate, so that means that every 30 years, the radioisotope is halved in intensity. So this patient walks around radioactive for the rest of his life. So we don't want that. Not for the patient itself, because, well, the patient we want to get the tumor cured, but for the surroundings. So if it's a young patient, it's still and it has a wife and kids, so you don't want to expose his kids to these radioactive seeds from the radiation that comes outside of his body. So that's why we mainly use this short half radioisotope, so 60 to 70 days. So this is a picture of how the seeds look. So this is the size of such a seed. And this is a patient with a prostate cancer. So this is a guidance who is placed in the rectum. Over here you see the prostate. This is the bladder and the prostate. So they insert needles which are with a holder. So it's quite invasive treatment to insert all these seeds. But it ends up like this. So if you then take an X-ray picture, you see that a lot of seeds are placed inside, well, its body. So, and if you do a high resolution CT, you will see that this is inside the prostate. So you're killing the cancer from inside out. Okay, let's move to some physics. First, before we're going to dive into really the die-hard physics, a lot of formulas, some definitions. So we're talking about ionizing irradiation, or ionizing radiation. So this is a radiation with sufficient high energy to kick out an electron from one of the shells, or one of atoms. So this can be the outer atomic shell, can also be inner atomic shells. But in such a way that it leaves a positively charged atom or releases a positively charged atom, which is also called an ion. So that's the reason why it's called ionizing irradiation. And it also kicks out an electron. So you will see some examples in a moment. So these ionizations, this can be direct. So it can be in such a way that you use particles. So particles are charged or uncharged pieces of matter. So it can be an electron, a positron, a proton, a neutron, an alpha particle, or a heavy charged particle. It can also be indirect, so by electromagnetic radiation. So this emits a photon, so is in essence uncharged, this photon, and this photon travels around and hits an atom, resulting in charged particles. So these examples are from this electromagnetic radiation are X-rays or gamma rays. So if you look over here, so this is sort of showing the wavelength area, going from radio waves up to gamma rays. So visible light is over here. So what we see is if you decrease the wavelength, you increase the frequency and you increase the energy of these photons. So in only gamma and X-rays and to some extent UV is able to show electromagnetic radiation, while visible light, infrared, microwaves or radio waves is a non-ionizing electromagnetic radiation. Why this is ionizing? So this causes, so these are photons which causes charged particles. These cause charged particles from start on. So why is this now important, this direct versus indirect? Because it defines what kind of damage you have. So over here you have an atom with its core, you have a photon coming in, it kicks out an electron. This electron can directly interact with the DNA and cause DNA damage. So this is with electrons and all other kinds of charged particles. It can also cause an indirect action by formation of hydrogen radicals as a result of the interaction of this electron with water. And since our body exists out of 70% of water, this is the more important way of how radiation interacts with the DNA. So this water gets converted into a hydroxyl radical. This radical damages the DNA. So now it's represented as an R with the radical. So it's a little point over here. And in this radical can be fixed into the DNA. So it's sort of a chemical fixation. So when you have these radicals, it can interact with oxygen, formation of an ROH, and when this is connected in the DNA, you get DNA damage, which is usually unrepairable. But I'm coming back to that in more detail later on in the biology part. So, since we're mainly talking about radiotherapy here with X-rays, I first want to go into some interactions of these X-rays with matter, so with tissue. So you can have no interaction, so that means that your X-ray passes completely through the tissue and can, if you have here, so this is a patient for example, suppose you have here an imaging panel next to the patient, so when you have no interaction you get complete penetration, so all your radiation go to the image. You can have also a complete absorption, so this X-ray energy can be completely absorbed in the body, so that's the second example over here. So no X-rays or no energy, no photons comes out of the body anymore. So this is impossible to do imaging when you have an imaging panel next to it, because you don't have any X-rays going through. So usually we never see top, we never see the middle, so we never see complete penetration, we never see total absorption. What we usually see is the bottom part, it's a partial absorption with scatter. So this means that you have an X-ray, gets absorbed on tissues, and your photon gets deflected in another direction. So with this you can do imaging again. However, it gets more difficult to do imaging because you don't have a straight line. So you each time have to calculate back from where is this signal coming from. And it's also a problem for the patients itself, and also for the staff members or the technologists who treat the patients, because usually they don't see these scattered photons. They go in any other direction except for a straight line. So it's hard to control for that. So also for that reason, the linacs in our institute are placed in bunkers. So we have walls of more than a meter concrete with steel inside, just to stop these scattered X-rays. So where does it start? So you have a patient, you have your X-rays. So does anyone has an idea where it starts? Does it start in the body itself, or in the organ, in the tissue, at the molecular level, or at atomic level? Suggestions? Who knows? Or who has an idea? Nobody? There are only 3 options. Okay, it starts in the atom. So the interaction begins in the body, begins at the atomic level. So we're going to discuss a few of these interactions, so photon interactions, which are relevant for radiotherapy. So you have Rayleigh scatter interaction, Compton photoelectric effect, pair production, and photonuclear effect. So for radiotherapy, only Compton photoelectric effect and pair production is important. So this Compton effect, so it's usually the dominant process within radiotherapy. It's used for radiation, for radiotherapy, it's used for imaging. And how does it work? So you have an incoming photon, or like over here, depicted over here. It hits an outer shell electron. So this is the atom with its electrons in different shells. So this incoming photon hits this electron, which is located at the outer shell of the atom. You get the formation of a scattered photon with somewhat less energy in a different direction, and you get kicking out of an electron, which is called a Compton electron. So this scattered photon, which with less energy, what can that do? So it can again interact with outer shell electrons from different atoms. So repeating of the whole process. So this interaction can occur until the energy gets too low, so below 0.1 mega electron volt, and if you are below that energy level, you see the photon electric effect occurring instead of the Compton effect. When it does not interact with other atoms, it can exit the body as a scattered photon. Thus this Compton electron which is released, it's an electron, so it causes a direct interaction, as shown at one of the previous slides. Okay, now we can go to some simulations. I hope this will work. So our physicist wrote a software program where we can simulate all these effects. Now I have to go back to see what. So we're going to work at an angle of 60 degrees for the scattered, and we will start with the energy level of 10 mega electron volts. So if you add here 10 mega electron volts and an angle of 60, this is how it looks. So you get your incoming photon. So this is the atom. It represents the electron on the outer shell of the atom. So what happens is you see that you get a scattered photon in a direction. So now I put it at 60 degrees. And you see that this electron shifts from yellow to blue, so it goes from an outer shell electron. It's a Compton electron, so this is representative of a Compton electron which is kicked out. So if you now decreasing the energy level to 0.1, and essentially you see that the same thing occurs. However, what's different is that this Compton electron is not traveling in a straight line anymore, but also now on an angle. and this angle is now as 55 degrees. So if you compare it to 10, you see that the angle from the quantum electron is almost a straight line, so 5 degrees. When you decrease your energy levels to 0.1, you see that in essence your quantum electron scatters in a different direction. So this is quantum effect. So when your energy levels drop below this 0.1 mega electron volt, you get the effect which is called the photoelectric effect. So it's important for low energy, and it's depending on the atomic number, on the Z value of your, on the Z value of your atom. So what happens is you get an incoming X-ray. This interacts with an inner shell electron. So not with an outer shell like the quantum, but with an inner shell. So really the first ring of electrons around the atom. So it interacts, the photon interacts with this inner shell electron. So and all energy of this photon is completely absorbed. So you get a full absorption. And you get the emission of a photoelectron. So what happens is you get here a free space. So there's a space free for an electron. So it is an inner shell vacancy, as it's called. So this atom is now highly unstable. So what this atom will do is it will recover an electron from the next shell, from an outer shell, to fill up these gaps. So this is what you see over here. So an electron from the L shell will move to the K shell, the one from the M shell will move to the L shell. So and these electrons have specific characteristics. So if you look over here, so the shell characteristics of this irradiation, so of filling the empty spaces, can be a fluorescent photon, so you can do fluorescent imaging with it, or it can be an Auger electron. So it's again an electron, you get a direct interaction that doesn't travel very far, this Auger electron, so you get a local energy deposition and damage. It's depending on the atomic number. So your atom needs to have an atomic number between 9 and 92, otherwise your photoelectric effect will not occur. And your photoelectric effect is better if you have higher atomic numbers. As well, the energy level determines the direction of the photon electron. So if you have high energy, photon electron will be in a straight line. If you have low energy, it will be again sidewise. So it's dependent on the atomic number, on the Z value. So this is the table of Mendeleev. So in essence, most of the atoms can have a photoelectric effect. Only above 92, so all those and in the 100 area or below 9, it's not possible. So what we will do as simulation is we use an atom with an atomic number of 72. We'll have a look on 2 energy levels, and then have also a look at what happens if you go below 9, an atomic number of 9. So there's also simulation for the photoelectric effect. So this is the incoming photon, the nucleus, the K shell, L shell. So we will start with an atomic number of 72 and an incoming beam of 10 mega electron volts. So what you see is, in a sense, you have your incoming photon. It kicks out the electron, which is a photoelectron, which travels in the forward direction, and that electron moves from the L shell to the K shell to fill up the gap. So if you now decrease the energy, so in essentially the same thing occurs. However, this photon electron gets emitted to the side. So if you go even lower, 0.02 for example, you see that now the direction of the electron, so the Auger electrons move in a different direction. So go back to 10 and use an atomic number of 8. you see what happens. Photon comes in, kicks out the electron. So the photon electron gets kicked out. The gap is filled by an outer shell electron which travels to the inner shell. However, you cannot emit a photon. So there are no shell characteristic irradiations anymore. So you don't have an Auger electron or fluorescence anymore. So the last last interaction which is important for radiotherapy is pair production. So this is important at high photon energy, so that we're talking beyond 16 mega electron volt. So what happens is you have your incoming photon. This interacts not with electrons this time. This interacts with the atomic core itself. So what happens of this interaction, you get the release of a negatron, so negatively charged electron, and a positron, or positively charged electron in essentially. So this is for high photon energy. If you go too high, so if you go beyond 20 mega electron volts, you don't get the release of a megatron or a positron, but you get the release of a neutron. So what happens is you get an inside the core you have protons and neutrons. So a neutron will be kicked out. When this interaction occurs in the close vicinity of metal, let's say for the machine from the LINAC, this metal becomes temporarily radioactive when you have above 20 mega electron volts and this release of a neutron. So we can have a look how this looks. So it's again depending on the atom number. So pair production, so we have an atom number of 74. This is the energy of the outcoming positron. Yeah, let's start at 6 mega electron volts. So this is one of the energies which is usually used in radiotherapy treatment. So you see again interaction of a photon with the nucleus, and a negatively and a positively charged electron is kicked out and spread in a divergent way. So what happens if you increase the energy level, you see that this angle of divergency gets smaller. You go even higher, so they keep to be close to each other. Yeah, and essentially this is not true. What you see now, so I inserted 20, or let's say let's use 25. And when you are above 20, so the simulation program doesn't count for that. When you're above 20, you don't see this anymore occurring, but one of the neutrons is kicked out of the nucleus. So in that sense, this is wrong. So what happens with this positron? A positron is a property of an unstable atom within radioactivity, in the radioactivity world. So this positron, when you have a radioisotope, it will emit a positron to become stable again. So what happens if you have a positron, I have it also over here, yes. So this positron, now I have to repeat what I inserted. 180. So what happens when this positron is released from a pair production? This positron travels around inside the body until it meets an electron. So then you have a plus and a minus which combine to each other to have an uncharged atom. So usually it hits again the outer shell electrons, like you see over here, and it emits 2 photons in opposite direction. So we have here in blue the positron which comes in, the outer shell electron, they form a pair again, and you have emission of 2 photons. So this whole process can keep on going and going and going. So each emitted proton that you have has always somewhat lower energy level. So you can really have a mixture of this Compton effect, photoelectric effect, and pair production, or this positron and electron annihilation, until you have stable atoms, sort of speaking. Good, so this is sort of the overview within radiotherapy. So this on the x-axis you have the photon energy in mega electron volt. This is the atomic number. You see that the Compton effect is the most dominant effect within radiotherapy. Pair production is usually seen at high photon energy levels. Photon electron effect is usually seen at low energy levels. So in Linux all effects can occur, usually in patients only the Compton effect. Okay, so what happens? When you irradiate a patient or a tumor, you get DNA damage. This DNA damage can be lethal, so that means it's irreversible, you cannot repair it, so cell will die. It can also be sublethal, so this means that it can be repaired within a few hours. And then when you give a second dose and your repair is not yet completed, this can interact with the not repaired DNA, let's say, from the first irradiation, and it will result in more damage, leading an ascension from sublethal goes to lethal damage. You can also have the potentially lethal damage, which can be modified by post-irradiation environments. So, within radiobiology, we have 5 R's, which stand for repair, repopulation, reoxygenation, redistribution, and radiosensitization. So if we look to the time between 2 radiotherapy fractions, comparing that to the number of cell killing, to the amount of cell killing, we see that repair occurs quite fast. So let's say this is 24 hours, for example. Your repair goes quite fast. When you have good repair, your cell kill will be low. Repopulation takes somewhat longer. So the repopulation means that tumor cells divide again, and that you get more and more tumor cells to fill in sort of the kill cells. So this takes longer, a period of 24 hours, but also leads to a decreased number of cell kill. When you have redistribution, you see that it's somewhat mid in taking how much time it takes, so from hours to days. But redistribution within the cell cycle is then causing more cell kill. The same with reoxygenation. So when you reoxygenate the tumor, so when you remove the hypoxic areas in the tumor, you will see that your cell kill will also be enhanced. So, the repair. So the repair of radiation-induced DNA damage occurs in between fractions. So not during irradiation, but really in between a fraction. It only occurs in cells which are sublethally irradiated. The repair is better in normal tissue versus tumor tissue. And why is that? Because most of the tumor cells or cancers have defects in their repair machinery. Repair itself occurs within hours after radiation, so it's fast. And the minimal time between 2 fractions to allow DNA repair on one day is 6 hours. So you can irradiate the patient in the morning and in the evening, having a fully repaired DNA. So DNA repair, you have several kinds of DNA. While you have several kinds of DNA damaging agents, you have several kinds of accompanying repair mechanisms. The most important for radiotherapy is this one, so it causes double-strand breaks, which can be repaired by homologous recombination, so HR, or non-homologous end joining, or, well, NHEJ. To give you an idea, if you irradiate a patient with 1 gray of X-rays, you get 1,000 single-strand breaks, you get 40 double-strand breaks, and 1,000 altered bases. These 1,000 single-strand breaks are very easily repaired, like this, and your repair is done, so to speak. These 1,000 bases are also very easily repaired, with a process called base excision repair. The 40 double-strand breaks are difficult ones to repair. So for each gray irradiation, you get 40 double-strand breaks, which are difficult to repair. How can you repair double-strand breaks? So one of them is non-homologous end joining. So you get a double-strand break, so this is a representation of your DNA. You get a gap, you get proteins which are attracted to this DNA, You get 6 key components, so Artemis, DNA, PK, CS, Q80, Q70, ligase, and XRCC4. You don't need to remember all those. So proteins are attracted to the DNA, and you get a religation or a fill-in of the gaps. So what we see in a lot of tumor cells are mutated for these DNA repair components, for these key components. And the mutation of DNA, PK, CS is one of the most occurring within tumor cells. These mutations cause that your cells are very radiosensitive. So you can see that over here in this graph. So this is dose, this is survival, this is wild type. So the parental cell lines or parental mice. You see you have a dose-dependent relationship between dose and survival. So when you mutate this DNA, PK, CS, you see a shift to the left. So you need a much lower dose to kill the same amount of cells. So your cells or your mice become more radiosensitive. The second way to repair your DNA double-strand breaks is done with HR. It's with homologous recombination. So you have again your gap. First, a protein which is coupled to this DNA strands is RAD52. This is called the recognition protein, so depicted here in green. This RAD52 activates RAD51, which makes sure that your accompanying strand, so your complementary strand, will invade into the second chromatin. So for HR repair, you always need your sister chromatin. Otherwise, it's not possible to invade. If you don't have a sister chromatin, you cannot invade anything. So this invasion of your sister chromatin will make sure that you uses the information of your sister chromatin to repair your initial chromatin by homologous recombination. If we compare both, we see that homologous recombination is mainly active in S-phase and G2-phase cells, while non-homologous end joining is effective throughout the whole cell cycle. Why is HR only effective over here? Well, because you need your sister chromatin, and it's only in S and in G2 that you have 2 chromatins. Non-homologous end joining repairs most of the double-strand breaks. It's important for radiosensitivity. It's error-prone, so that means that you can introduce errors during a repair. It's all part of the cell cycles. The half-life is 2 to 4 hours. So within 4 hours, let's say half of your DNA damage is repaired. Defects are rare in cancer but occur, and it's mainly important for non-proliferating tissues. Homologous recombination was the other 20% of the repair. It's also important for radiosensitivity. It's error-free. You have a correct sister chromatin. So it uses the information of your correct sister chromatin to repair the double-strand breaks, and in that sense it's error-free. It's only S and G2 phase. It's responsible for changes in sensitivity within the cell cycle because it's important in S and G2. It varies between cell lines, so it's very high in stem cells. Its defects shows a lot of defects in cancer, and it's important for proliferating tissues. So if we go to the next R, so it's the repopulation. So it means the outgrowth of surviving or resistant cells. It's important for fast dividing tumors, and overall treatment time is important. I have two very old curves. So time on the x-axis, number of cells on the y-axis. So this is how a cell grows over time, for fastly proliferating and slowly proliferating. So you see that the slope of it slowly is steeper compared to is less steep, than the rapidly. So if you irradiate over here, you see that you get a number of cell kill. So you go from 10 to the 12th to 10 to the 9th surviving cells. So usually what we see if you hit fastly proliferating cells or tumors, they tend to grow even faster. The outgrowth is even faster after irradiation than before. So your slope becomes even more steep. While for slowly proliferating tissues, you irradiate, you get cell kill, they grow back at the same speed as the initial growth. So your repopulation is very important for these fastly growing tumors because the tumors can grow even faster. The overall treatment time is important. So when you give 70 grade 2 patients spread out in fraction of 7 weeks, and you compare that to 70 grade 2 patients spread out in fraction of 6 weeks, 2 grades per fraction, you see that your 6 fractions per week gives a better survival. So this is local regional control, better survival over time compared to 5 fractions per week. So if you irradiate faster, from giving more fractions a day, it's better for cure. The reoxygenation, well, this is linked to tumor hypoxia. You got that lecture in the previous block. So when you have hypoxic tumors, they cause radioresistance. So tumor cells become resistant to radiotherapy. So this is again the same graph as I showed a few months ago. When you have oxic tumors, you get a dose-dependent relationship with the survival and the radiation dose. However, when your tumors become hypoxic, what happens is they interact or they confer with this indirect action mechanism. So you have this radical which needs oxygen to fix your damage into the DNA strand. So when you don't have oxygen, what happens is that the protons, the free protons, interact with this hydroxyl radical and form water again. So you irradiate, but you don't have damage anymore because free protons interact with this hydroxyl radical and form water. So you never reach your DNA strand when you do not have oxygen. So this is seen over here that you need to have much more dose to have the same level of cell count. Now this is called oxygen enhancement ratio. So how can we reoxygenate? Well, you can do it in a passive way. So during fractionation, so in between fractions, tumor cells, well, when they are in close vicinity to vessels, they will reoxygenate. You can also do it in an active way by giving patients EPO, carbogen nicotinamide, terpazamine, hyperbaric oxygen. So for example, this is with the hyperbaric oxygen. So you let the patient breathe 100% oxygen. So you see that your survival or your local control is much better when you breathe oxygen compared with regular air. For the next R is the redistribution R. So it defines the sensitivity depending on the cell cycle. So sensitivity is usually low in G1S and is high in G1S and late G2M phase. Or when you see over here, this is dose to the survival. These cells are sorted out, so you have here only M phase and G2 block phase, G1 block phase, early S phase, late S phase. So you see that that mainly G2M and G1 arrested cells, which are irradiated, show much more sensitivity. So you need to have lower dose to have the same number of cell count. And the last R is the one from radiosensitivity. So this defines the this is an intrinsic characteristic of tumor cells, which can be very sensitive, radiosensitive. So these are like lymphomas, seminomas, embryonal cancer, small cell lung cancer. So this means that you have to give a low dose to get rid of your tumor. You can also have very insensitive or radioresistant tumors like sarcomas, glioblastomas, or brain tumors, kidney cancer, in which the dose is doubled compared to sensitivity in an attempt to cure the cancer. So we're coming to the question, why is cancer treatment so difficult? So this is a cartoon where you have the number of cells and doublings. So you see that you need to have 10 to the 9 cells to reach this point to become in the clinical observable phase. So when you are at 10 to the 9 cells, you have a tumor of 1 gram or 1 cubic centimeter, which can be detected by the current imaging devices we have. So if you go up to 10 to the 13th, you get a tumor of 1 kilogram. So it's only in this phase where patients see a doctor. What happens before, which is the silent interval, well, patient has cancer, but it's not detectable yet. So what happens then during treatment? So this is presentation, go to the doctor, 10 to 12 cells. Patients will be treated with irradiation, chemotherapy, surgery. So you see a huge, fast decrease in number of cancer cells. However, so this the threshold of 10 to the 9th, you're below that. So This is called remission. So if a cancer do not relapses, it's called a cure, otherwise it's a recurrence. The problem is that in this phase you cannot detect the cancer because it's just too small. So the current imaging devices cannot detect this cancer. To treat a tumor, 10 to the 12th number of cells. If you kill 99.99% of the cells, you still have 10 to the 8 viable cells left over, which fall below the detection limit or threshold of 10 to the 9th. So usually, well, the doctor says, yeah, you're cured. However, you still have 10 to the 8 viable cells, so this is not a cure. When to have a cure, you need to kill at least 9 logs, so this 99.9999, a whole bunch of 9s, % of the cells need to be killed to cure a tumor. More different reasons than only cell kill is also that the tumor is heterogeneous. So this is the concept of tumor microenvironment. So this is a biopsy of a head and neck squamous cell carcinoma, stained for different markers. So in red it's a blood vessel, purple shows the proliferating cells, green shows the hypoxic cells, and here in orange is the necrotic cells. So at a microscopic level, the tumor is very heterogeneous. And we showed before that when you have hypoxic cells, that this is resistant to radiotherapy. When you have fastly proliferating cells and you irradiate them, they even proliferate faster. So the tumor is not a homogeneous entity, but very heterogeneous. So this also is also one of the reasons why cancer treatment is so difficult. So how can we increase the effect of radiotherapy, or how can we increase the therapeutic ratio? So over here you have the tumor dose and an effect. So to kill the tumor, which is more sensitive than normal tissues, you have to give a certain amount of dose. So to get 100% of dose, preferably you want to give this amount of dose. However, we notice that to get 100% tumor cure, we see that 75% of our normal surrounding tissues is also damaged. So in a sense, that's not what we want. So we want to spare normal tissue. So what we do want is 0% damage to normal tissue. However, this means that we only have 75% effect on our tumor. So we don't have the maximum capacity to kill the tumor. So this means that normal tissue is a limiting factor for tumor control. So what can we do? We can decrease the sensitivity of normal tissue, so by fractionation. So we move up the curve of normal tissue to the right by fractionation. So fractionation allows cells, normal cells, to repair their DNA damage and to repopulate. It allows also reoxygenation, so you get a better oxygen enhancement. It allows redistribution of the cell cycle. So the consequence is that it decreases the overall treatment time to make sure that your clonogenic proliferation between doses decreases. And it enhances the difference between the early responders, so the fast-growing tumor cells, and the late responders, or the normal tumor cells, the normal tissues. So you can also do it the other way around. You can shift your tumor control curve to the left by targeting biological pathways. I showed you some examples in the previous blog. It's, for example, with autophagy blocking with chloroquine that sensitizes radiotherapy. So, at the last part of the lecture, I'm going through the different parts if a patient presents himself to a radiotherapy department and what happens. So the patient gets first a scan to detect the tumor. So it can be a PET scan, PET-CT, or a CT scan. So it's detection phase. Second phase is delineation of the tumor and normal tissue boundaries. Then you do a treatment planning, so you really confine your beams of your irradiation towards the target, towards the tumor, and then you do verification. You want to guarantee that the treatment that you gave is the proper treatment. So, as detection, usually we use PET-CT. So, PET stands for positron emission tomography, gives functional information. CT is computed tomography, gives anatomical information. And nowadays there are also combinations available for PET MRI, so MRI is magnetic resonance imaging. So these images look like this. So you see the bony anatomy in white from the CT, which is gray is more soft tissue anatomy from the CT, and then you see here tumor hotspot colored in yellow as a result of FDG PET imaging. Then step 2, you delineate your organs of risk, so your normal tissue and your tumor volume. So this is now a 2D representation, so you immediately see that it's hard to see where the tumor is, where the liver is, heart, pancreas, stomach, kidneys. So what we are doing nowadays is we do that in 3D. Has anybody any idea what organ this is? Suggestions? This is the stomach. This one. Come on. It's one of the kidneys. This. Yeah, the other kidney. Good, thanks. What's this? It lays on top of the stomach. The lungs and the heart. Lungs and heart. It's a combination of both. What do we see here? What goes from brain to tail, so to speaking? Spinal cord, or the spine. What's this is? Oh, sorry. Yeah, this was the spleen. I gave it away. What's this? Pancreas. What's this? Liver. Yes. Wow. I have 2 out of correct. What's this? Any ideas? This is the tumor. Or the target. So this is the target volume. So you immediately see that this tumor is surrounded by liver, kidneys, stomach, heart, lungs, spleen. So it's very hard to irradiate such a tumor because of all these surrounding healthy tissues that you want to spare. So this is how we end up with treatment planning. We optimize for the dose for energy, the direction, the shape, the size. So over here you see the target, and it becomes more and more yellow when we give more and more beams from different angles. So these are sort of representation of the beam. So this is a beam and beam and beam. So we do that in such a way to hit the tumor as maximum as possible and to spare healthy tissue as maximum as possible. So this is sort of how it looks. So when you optimize the treatment in a perfect way, you see your tumor completely in red, gets maximum of the dose, while the surrounding tissues are in bluish to get, so blue indicates lower dose. So this treatment plan seems to be very good because your shape of your tumor is like completely in red, yellowish red, while all your normal organs are in blue. So yeah, then when you have that, you irradiate your patient, and you make sure that, so during irradiation, this is a patient, irradiation. So during the treatment, you activate your imaging panel, as shown in the beginning of the lecture, and you can compare what is predicted, so from your treatment planning, and what's measured from the actual treatment itself. And you can make the difference of it, and you see then this in different colors. So bluish indicates that predicted versus measured is okay. More red indicates that there's an error. So that gives you an indication how to change your treatment plan. However, we have some problems in clinical practice. So, and the solution for this problem is IGRT, image-guided radiotherapy. So this is a picture of a lung. So can somebody say me where the tumor is? It's not in the red circle. I mean, the red circle does not represent the tumor. This is the tumor. Only this spot, you hardly can see it on CT. This is the tumor. This is just regular lung, the rest, but it's collapsed. So it's a collapsed lung. So we need images, image-guided radiotherapy with PET. So this is now an example of PET, to identify the tumor inside, for example, a collapsed lung. Otherwise, if you have only CT information, you irradiate the whole lung. You irradiate this whole circle, which is not the correct way to go. Another problem is the problem of the dancing tumor. So this is a lung tumor, and the tumor moves upside down. So I drew a circle on here. This is where the irradiation beam is. And you see that this tumor goes outside, inside, outside, inside, outside, inside the beam, based on respiration. So what should the patient do to be efficiently treated? Stop breathing. Well, you can't do that. You cannot ask the patient that he stops breathing. So what happens is that breathing patterns will be monitored of the patient, and each time that he inhales, for example, you put on the irradiation beam. When the patient exhales, you stop. So you irradiate like in a sinus wave because of these dancing tumors. This occurs not only in lungs but also in bowel. Another way to irradiate better is usually when you have a target, we use a margin of 5 millimeters to guarantee that all micro tumor cells or only cells will also be irradiated. So you can reduce this margin from 5 millimeters to a lower margin, let's say 2 millimeters. And in essential, this leads to a reduction of 50% of the irradiated volume. So you can see it as an orange. When you take off the peel of the orange and stack the peel, you see that the peel has the same volume of the orange itself. Something which we recently noticed is that you do a pre-treatment FDG scan. So this is the tumor. So you irradiate the whole tumor. And when the patient represents itself 3 months after radiotherapy, you see that there's again some FDG activity present in these examples. So what we noted is that FDG uptake present in these tumors after radiotherapy is actually localized inside the image from pre-treatment. So the resistant, not cured tumor cells or voxels are in the pre-treatment image available. So there are different regions in the tumor which need different doses based on tumor microenvironment, heterogeneity, and resistance. So how can we identify those? So in the up to, let's say, 5 years ago, so this is a tumor, the grid represents the beams of the radiation. A flat dose was given with the idea that the tumor is a homogeneous entity. So this is excellent when your tumor is homogeneous. However, we do know that a tumor is not homogeneous, it's heterogeneous. I showed you that with these biopsies from head and neck. So if you give a flat dose to a heterogeneous tumor, your survival is not flat, it's heterogeneous. So there will be more tumor cell survival in resistant areas, and you do an overkill in sensitive areas. So nowadays we do it this way. So heterogeneous dose to heterogeneous tumor, making that your survival is again flat. So you do a redistribution of the dose, more to resistant areas, less to the more sensitive areas, and you do an optimal tumor control with the same dose on normal tissues. Well, it's possible, so it's not yet implemented in clinic, but it's possible. So we did a study in rats, and this is a rat, yeah, it's hard to see. This is the tumor where we give a homogeneous dose. So you see it's all red, the tumor is all red. And we give it another tumor, another animal, a heterogeneous dose. So the whole tumor is located over here, or you can better see it over here. So this is the tumor. So we gave more dose to the top part and less dose to the bottom part. And now we're investigating if we actually have a better cure on these tumors. So what needs to be done, this is one of my last slides. We need to combine all these different techniques to try to treat the patients, that we kill the tumor and that we really save normal tissues. So this is how it occurs. So this is a brain tumor over here. But, this is how this patient is treated nowadays. So you get a high dose in the tumor, but you get quite some dose, as seen here in this bluish, in your normal brain. What needs to be done is, so this is sort of how it is done today, and this is the dose profile. So you see a peak and a long edge, and when we look into depth into the tissue. So it's possible with particle therapies, with proton therapy to really, so this is the dose profile, so it's very low, 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 low. It peaks at a certain distance, at a certain depth in tissue. So that's what we want to use to actually irradiate only the tumor and save most of the normal brain in this case. So you see that the normal brain with this proton therapy plan is saved as much as possible, or much more compared with this one. So we're building at the moment a proton therapy center over here in Maastricht. This is sort of a very small picture how it looks like. So in Ascension it will be combined with the tube that they're making it on the highway, because there we need to start to generate our protons to get them over here, so next door, so in 40, Master Clinic lays over there, to get them with sufficient energy level. So yeah, it will still take a while before we can actually treat patients with particle beams or protons. Thank you very much. The questions?
Dat we niet doen met die elektronen, de andere kant op gaat.